We're now going to move to a review of trauma from head to toe. We're going to begin with head trauma. Opinion number one, an 18-year-old man arrives in the ER with an axe firmly implanted into his head. Although it is clear from the size of the axe blade and the penetration that he has sustained an intracranial wound, he is awake and alert and hemodynamically stable. This is based on an actual patient we had. This can happen. The point of this vignette, though, is any penetrating injury of the skull will need eventually to go to the operating room, where the neurosurgeons will repair whatever damage was done by the penetrating weapon. But there is another angle to this vignette, which is also nicely illustrated by the circumstances here. It is in fact in that operating room where that foreign body should be removed. In other words, if this vignette offers you as an option to remove that axe in the emergency room, that would not be a correct answer. The patient who arrives with an impaled foreign object should be left with that foreign object there until he's in the operating room, anesthetized, the team is scrubbed, gowned and gloved and ready to go. Because when we remove the foreign body, there can be bleeding, there can be problems that develop that the presence of a foreign body was tamponating and preventing. So the answer on this gentleman is taken to the operating room, have the neurosurgeons remove the axe and repair the damage that might have been done by the axe. Vignette number two reads, in the course of a mugging, a man is hit over the head with a blunt instrument. He has a scalp laceration, and CT scan shows an underlying linear skull fracture. He's neurologically intact and gives no history of having lost consciousness. Let me read the next vignette because I want to make a contrast between the two. In the course of a mugging, a man is hit over the head with a blunt instrument. He has a scalp laceration. CT scan shows an underlying comminuted depressed skull fracture. Is neurologically intact, gives no history of having lost consciousness. Both of these are patients who were hit over the head. Both of them have a scalp laceration, and both of them have a fracture of the skull. But in one case, it is a linear skull fracture. In the second case, it is comminuted and depressed. The first of these two could be cleaned and the wound repaired, sutured in the emergency room. The second one will have to have it done in the operating room. In other words, when there is a depressed, comminuted skull fracture, the neurosurgeons have to pick those little pieces of bone out of the brain in the operating room. Now we move to vignette number four. A pedestrian is hit by a car. When brought to the ER, he has minor bruises and lacerations, but is otherwise quite well, with a completely normal neurologic exam. However, the ambulance crew reports that he was unconscious at the site, and although he woke up during the ambulance ride and is now completely lucid, he does not remember how the accident happened. This is a very important issue here. In the US of A, highly technological environment to practice medicine, any trauma patient who gives a history of having lost consciousness, even if he's now regained it, even though his neurologic exam is now normal, that individual needs a CT scan of the head. Obviously, we're looking for the early signs of intracranial bleeding. We don't want to wait until he's got a big hematoma and a lot of problems. But that's a correct answer in this vignette. This individual needs a CT scan of the head. We're now going to move to vignettes 5 through 8. There's an underlying theme to all of those. The pedestrian is hit by a car. He arrives in the ER in coma. He has ecchymosis around both eyes, raccoon eyes. Pedestrian is hit by a car. He arrives in the ER in coma. He has clear fluid dripping out of his nose. Pedestrian is hit by a car. He arrives in the ER in coma. He has clear fluid dripping from the ear. Pedestrian is hit by a car. He arrives in the ER in coma. He has ecchymosis behind the ear. All of these you remember from medical school. These are signs of a skull fracture at the base of the skull. That is cerebrospinal fluid leaking through the nose or through the ear, and those hematomas are classical, the raccoon eyes or the hematoma behind the ear. Now, at one time, the fact that a patient had a base of the skull fracture led to some therapeutic interventions that have been discredited. We used to operate everybody had one of these. We realize now that all of them do not need to be operated. We used to put them on antibiotics thinking, well, the bugs can get into the base of the skull. That was not the main issue. The main issue, in fact, is that in order to have a fracture of the base of the skull, you need big trauma. And if you had big trauma to the head, you have to remember that the head is connected to the rest of the body by the neck. If you have big trauma to the head, you may have sustained also trauma to the neck. This patient could have cervical spine injury, perhaps even a spinal cord injury. And because all four of them are in coma, you cannot ask them to wiggle their toes. You cannot go by clinical findings. Now, all four of these are unconscious trauma patients. They're all going to need a CT scan of the head. What they also need, and that's the correct answer, is they need that CT scan to be extended. So it includes the head and the neck. The CT scan is the best study we have to, in the emergency room, in a quick way, give you the answer as to whether there is a cervical spine injury or not. So let me repeat the correct answer on all four of these. CT scan of the head extended to include the neck. Now we move to vignette number 9. A 14-year-old boy is hit over the side of the head with a baseball bat. He loses consciousness for a few minutes, but he recovers promptly and continues to play. 1 hour later, he's found unconscious in the locker room. His right pupil is fixed and dilated, and there are signs of contralateral hemiparesis. Okay, let me review this. There are 5 findings here. There was trauma to the head. There was loss of consciousness. There was a lucid period when the patient woke up again. There was a second situation of the patient going into coma. And then finally, the 5th thing is there are now findings, a dilated pupil on one side, hemiparesis on the other. These 5 things, this sequence of 5 events, can happen in either an acute epidural hematoma or an acute subdural hematoma. In general, you suspect it is an acute epidural if the trauma was relatively trivial, although very strategically placed on the side of the head, where it can get the middle meningeal artery. And if this lucid period was such that the patient was completely normal during that lucid period, went back to doing whatever he was doing before. And you suspect the acute subdural if it was bigger trauma and sicker patient with barely being awake in the lucid period. You don't have to rely on those clinical hints, though, because both of these patients are going to get a CT scan. Remember, anybody in the US of A gets hit over the head and loses consciousness gets a CT scan of the head. If the diagnosis, in fact, is an acute epidural hematoma, there will be the classical biconvex, lens-shaped hematoma. The diagnosis, on the other hand, is acute subdural. There will be the crescent-shaped semilunar hematoma. Let me repeat this. I'm going to cut away from my face now to words on the screen. We're going to repeat this one more time. So we are talking about, first, a sequence of 5 events. Those 5 events, as you read the vignette, are trauma to the head, briefly unconscious, wakes up, so-called lucid interval, goes into coma again, and then is found to have one pupil that is fixed and dilated and have contralateral hemiparesis. You realize when you read a vignette that has those 5 findings, that that patient could have an epidural hematoma or an acute subdural hematoma. You suspect the epidural with trivial trauma and a completely normal patient during the lucid interval. You suspect, on the other hand, the acute subdural if there was severe trauma and a barely awake patient during the lucid period. You're going to do a CT scan in either case. If the CT scan shows a biconvex lens-shaped hematoma, it is an epidural hematoma. And we treat that with a craniotomy to evacuate it. And yeah, there you have an example. You can see the classical biconvex hematoma that is the acute epidural. But on the other hand, if the CT scan shows a semilunar crescent-shaped hematoma, then the diagnosis is acute subdural hematoma. Now, for the management of the acute subdural, if there are clinical and radiological signs of a midline shift, then we do a craniotomy and evacuate the hematoma. But if there are no signs of a midline shift, then we monitor intracranial pressure and treat medically as needed. And there is an example of a semi-lunar hematoma, and you see the displacement of a midline structure. So this is a patient who would, in fact, benefit from a craniotomy and evacuation of a hematoma. This is a large subdural hematoma with a midline shift. Let's now move to vignette number 11. A man involved in a high-speed head-on automobile collision is in coma. He has never had any lateralizing signs. That means he doesn't have a dilated pupil on one side but not on the other. He doesn't have hemiparesis on one side but not on the other. And the CT scan shows a small crescent-shaped hematoma, but there is no deviation of midline structures. Well, now, this is a subdural hematoma, but there are no findings that would suggest that he would benefit from surgery. He needs intracranial pressure to be monitored and treated medically if needed. Let me go to another vignette that will review this issue again. This is now vignette 12. A patient involved in a head-on high-speed automobile collision arrives in the ER in deep coma with bilateral fixed dilated pupils. CT scan of the head shows diffuse blurring of the great white mass interface and multiple small punctate hemorrhages. There is no single large hematoma or displacement of midline structures. Here again we're talking about trauma to the head with damage, but no evidence of a hematoma that needs to be surgically evacuated. The management on this patient will be monitor intracranial pressure. If it is elevated, we treat that medically. Fluid restriction, diuretics, preferably osmotic like mannitol, furosemide can also be used. Hyperventilation. The idea is not to overdo either of these to where the patient is driven into shock, because we want to preserve intracranial perfusion. So just enough to lower the intracranial pressure. If this is not successful, we can then reduce the oxygen demand on the part of the brain, which can be done with sedation or hypothermia. We're now going to move to another vignette, vignette number 13. A 77-year-old man becomes senile over a period of 3 or 4 weeks. He used to be active and manage all of his financial affairs. He now stares at the wall, barely talks, and sleeps most of the day. His daughter recalls that he fell from a horse about a week before the mental changes began. When you read on an exam question that an old man is no longer terribly bright, you would think there are many, many possibilities for that. He could have developed Alzheimer's, he has developed senile dementia, he's got arteriosclerotic changes in his brain perfusion. But none of those things develops over a 2 or 3 week period. So when you realize in an exam question an old man used to be bright and awake and alert and very smart, and a few weeks later he's not, this is not one of those degenerative things. This man, you then realize as you read the vignette, had minor trauma to the head. What this man has is a chronic subdural hematoma. A chronic subdural hematoma. It's something that cannot happen to anybody. It happens only to very old patients or to alcoholics. By virtue of old age or alcoholic abuse, the brain has shrunken. It's now smaller than it used to be. But the cranial bone doesn't shrink along with the brain. So now there is a relatively small brain and a relatively big head. And minimal trauma can rattle that brain around, can tear one of the venous sinuses. The patient bleeds slowly into the head, and within a week or 2 or 3, as the mental changes that were described here. What you do in this individual is you do a CT scan of the head, you'll see the hematoma, you evacuate that hematoma surgically, and that patient is going to be bright again, because this is what was responsible for the change in his mental status. And vignette number 14 is one that is a repeat from a previous one, but it's an important one. 45-year-old man is involved in a high-speed automobile collision. He arrives at the ER in coma with fixed dilated pupils. He has multiple other injuries, including fractures of the extremities. His blood pressure is 70/50 with a feeble pulse at a rate of 130. What kind of intracranial bleeding is responsible for the low blood pressure and the high pulse rate? And you already know the answer. None. You cannot bleed enough volume of blood into the cranial cavity to go into shock. It's bleeding someplace else. All right, we're going to go into neck trauma. Let me have a little introduction before we do the vignettes of neck trauma. A lot of the trauma that we're going to be reviewing, it's going to be either penetrating trauma or blunt trauma. And as a rule, penetrating trauma is easy to diagnose and easy to manage. Most patients with penetrating trauma end up in an operating room having some surgical repair of whatever was damaged by the penetrating weapon. Blunt trauma, on the other hand, is a lot more complicated. It needs a lot of studies and it needs a decision as to whether an operation is needed or not. However, in the penetrating trauma, there are also exceptions. So even though the rule is most patients with penetrating trauma end up with an operation, not all of them do. So as we go through our neck trauma vignettes, we'll have a good opportunity to see where indeed we do an exploration and where we do not. So let me begin with vignette number 15. A man has been shot in the neck and his blood pressure is rapidly deteriorating. Hey, you know what to do with this one. Even before we reviewed neck trauma, you already knew that if a trauma patient is going into shock and we know where he's bleeding from, the thing to do is to operate and stop the bleeding. And here's a good example. He was shot in the neck, he's gone into shock, we know he's bleeding in the neck. He needs a surgical exploration of the neck. Let's move to vignette number 16. 42-year-old man is shot once with a .22 caliber revolver. The entrance wound is in the anterior left side of the neck at the level of the thyroid cartilage. X-rays show that the bullet is embedded in the right scalene muscle. He is spitting and coughing blood and has an expanding hematoma under the entrance wound. His blood pressure responded promptly to fluid administration and he has remained stable. Embedded in this vignette, in fact, there are several indications for surgical exploration of a penetrating neck wound. One of them is the location. The vignette points out that the entrance wound is in the anterior left side of the neck at the level of the thyroid cartilage, that the bullet is embedded on the other side, and as a rule, most gunshot wounds of the middle part of the neck, what is called zone 2, below the angle of the mandible, above the cricoid cartilage. As a rule, most of those require surgical exploration. But in addition to that, he has evidence of injuries. He's spitting up blood and coughing blood. Well, that means there is an injury to the trachea or the larynx or the esophagus, and those have to be repaired. And also there is an expanding hematoma, which means there is an injury to a major vessel. So you have three indications here: the location, gunshot wound to zone 2, the fact that he's spitting up blood and coughing up blood, and the fact that he has an expanding hematoma. Even though in this case you don't have the indication we had on the previous one, which was he was going into shock. But now as we move into the next couple of vignettes, we're going to see exceptions to the rule that says most gunshot wounds end up with a surgical exploration. Vignette 17. A young man is shot in the upper part of the neck. Evaluation of the entrance and exit wounds indicates that the trajectory is all above the level of the angle of the mandible. A steady trickle of blood flows from both wounds and does not seem to respond to local pressure. The patient is drunk and combative but seems to be otherwise stable. Now that particular location, above the angle of the mandible, is very difficult to explore surgically. It can be done, but it's a very difficult operation. And at that level, we don't have to worry about the trachea, we don't have to worry about the esophagus. The only major problem would be a vascular injury. And a vascular injury up there would not be easy to manage surgically either, because the distal control would be difficult to get as that vessel goes into the cranial cavity. So by far the best way to proceed with this one is radiologically. The correct answer here is this patient has an arteriogram, an angiogram, that's the same thing done, and then he has arteriographic or angiographic assessment of the vascular tree, diagnosis of an injury, one is there, and management by embolization of the bleeding vessel. And vignette number 18 shows another specific situation with penetrating injuries to the neck. A young man suffers a gunshot wound to the base of his neck. The entrance and exit wounds are above the clavicles but below the cricoid cartilage. He is hemodynamically stable. In that location, below the cricoid cartilage, this is the boundary between the neck and the chest. And it is preferable, if at all possible, to know ahead of time exactly what injuries are present, so we can plan the operation, so we can decide whether we can do the surgical exploration through the neck, or we need a medium sternotomy, or we need a trapdoor incision, or a combination of the above. So if at all possible, we want this gentleman to get an angiogram, that is to say an arteriogram, an esophagogram, esophagoscopy, and bronchoscopy. And once we have all that information, then we can proceed. Now, the previous 4 vignettes we read were gunshot wounds. This next one is going to be a stab wound. So let me stop here for a second to go into some basic background here. In the management of penetrating wounds, 2 assumptions are made that guide our therapy. One of those 2 assumptions is bullets do more damage than knives, and therefore we tend to be more aggressive with gunshot wounds than we are with stab wounds. The second assumption is based on what part of the body had the gunshot wound or the stab wound. There are some parts of the body that we know are full of critical organs that if they are injured will give us a lot of trouble, and other parts that are not. So when we put together the 2 thoughts, is it a gunshot wound or a stab wound, and where is it in the body, we have a pretty good idea whether we're going to need to operate because it is a bullet in a critical place, or we don't need to because it is a knife or a bullet in a place that is not as critical. Well, here is a good example. In the course of a bar fight, a young man is stabbed once in the neck. The entrance wound is in front of a sternomastoid muscle on the right at the level of the thyroid cartilage. The patient is completely asymptomatic and his vital signs are completely normal. Well, we don't have any evidence of damage. We can go on the assumption that a knife does less damage than a bullet, and given the fact that he doesn't show any evidence of damage, this is a patient we could safely watch, follow him clinically rather than intervene surgically. I hasten to add that this identical vignette, if it had said that he has an expanding hematoma in the neck, or if it had said that he is going into shock, or it had said that he's spitting up blood and coughing up blood, then you realize that even though it was a knife rather than a bullet, that in fact in those cases an exploration would be needed. But as it reads, he does not. Now we move to vignette number 20, an example of blunt trauma to the neck. A patient who was the unbelted right front seat passenger in a car flies through the windshield when the car crashes into a telephone pole at 30 miles an hour. He arrives in the ER strapped to a headboard with sandbags on both sides of the neck. He has multiple facial lacerations but is otherwise stable. Examination of the neck reveals persistent pain and tenderness to palpation over the posterior midline of the neck. Neurologic examination is normal. Well, in blunt trauma to the neck, the big issue, of course, is cervical spine injury. And from that, potentially spinal cord injury. Well, here we have a patient who's saying it hurts in a particular place. And even though he's neurologically normal, already the EMT suspected that he was going to need the head immobilized and sandbags and the headboard because of the findings that he has. And indeed, what this gentleman needs is we need to evaluate his cervical spine. And the best way to do that would be with a CT scan. Let me have a little review, a little repetition. We have talked about when do we have to explore injuries to the neck. Let's cut away from my face to pictures on the screen so that we can remind ourselves once more what are the indications for surgical exploration in penetrating injuries of the neck. One of them is the vital signs are rapidly deteriorating. Another one, an expanding hematoma. Another one, the patient is spitting up blood or vomiting blood. And the fourth one, gunshot wounds to the middle zone of the neck. On the other hand, alternative management of penetrating injuries of the neck include, if it is above the angle of the mandible, it's better to do arteriographic diagnosis and treatment. And if it is below the cricoid cartilage, it is better, if at all possible, to do an arteriogram, esophagogram, esophagoscopy, and bronchoscopy before we operate. And with that, we're going to move to another little chapter on spinal cord injuries. We've been talking about, in the last vignette, patient with blunt trauma to the neck and how that leads to evaluation of the cervical spine, because that could have led in turn to damage to the spinal cord. So this is a good point to remind ourselves of spinal cord injuries. Let me review these vignettes. Vignette number 21. An 18-year-old street fighter gets stabbed in the back, just to the right side of the midline. He has paralysis and loss of proprioception distal to the injury on the right side, and loss of pain perception distal to the injury on the left side. This is the classical hemisection of the spinal cord, the Brown-Sequard syndrome. Now, if you remember where all the tracks are in the spinal cord, if you have that knowledge of neuroanatomy, you could, with that, realize what's wrong with this man. But even if you don't, when you read on a question that there was a stab wound, and now certain neurological functions are absent on one side below the lesion, and a different group of neurological functions are absent on the other side below the lesion, you know that is a hemisection. The next one, vignette number 22, says a patient involved in a car accident sustains a burst fracture of the vertebral bodies. He develops loss of motor function and loss of pain and temperature sensation on both sides distal to the injury, while showing preservation of vibratory sense and position. Now, this is an anterior cord injury. Now, you remember enough anatomy to know that the vertebral bodies are in front, the spinal cord is behind. If a vertebral body blows up, it stands to reason that the anterior part of the cord is damaged. And this is confirmed by the fact that vibratory sense and positional sense are preserved because they travel in the most posterior part of the cord. Let me move to the next. Then we're going to talk about management for all of them. This is vignette 23. An elderly man is involved in a rear-end automobile collision in which he hyperextends his neck. He develops paralysis and burning pain on both upper extremities while maintaining good motor function in his legs. This combination, an old patient, hyperextension of the neck, the upper extremities have problems, the lower extremities do not. This identifies for you the central cord syndrome. Now, as for management, we have to start with a precise diagnosis. We've been talking about the CT scan being our most practical and best diagnostic tool to assess what has happened to the cervical spine, to the bones. But if we need to know what has happened to the spinal cord, MRI is a better option. So in terms of the management, the assessment of the damage, the precise diagnosis is done with an MRI. I think beyond that, the question is unlikely to ask you for more details on management, because the management of cervical spine injuries with spinal cord lesions is pretty complicated. The spinal cord feature of that particular lesion, there is a lot of controversy how best to treat. However, there seems to be some benefit from high-dose steroids administered as soon as possible after the injury, and that might appear as an option on your answers.